factors for suicidal thoughts and behaviors in young adults. He loves playing soccer and eating proper pizza. And I know that to be true and that to be long-standing interest for him, because I also went to the University of Utah and got my PhD there in child clinical and developmental, and have known Mikle for many years and his love of New Haven pizza. Welcome, Mikle.
Thank you, Kelly. It's great to be with everybody and to just share some thoughts about mental health and autism. Specifically today, focus on depression. But anybody that works with autistic children, adults, families knows that co-occurring mental health concerns are common and often a significant challenge in maximizing opportunities for success. So as Kelly said, feel free to chime in on the chat at any time and she'll interrupt me. I'm just happy to take questions. Make this as much as a discussion as we can, given that we're in different places meeting via technology. Before I start, I just want to make sure that you know I have no conflicts of interest to report. And I also always want to talk about language. Many of you are familiar with the discussion around person first versus identity first language and the reasons for it. There's not a lot of data out, but the data from autistic self-advocates that we do have shows a preference for identity first language. I may use a mix out of respect to different points. We'll tend to land on identity first language out of respect to the preferences of our self-advocates. I also really need to start out with a shout out to the people I work with. This is our BYU Autism Connect team, a multidisciplinary team from across campus, from multiple departments. We've had a lot of support from the BYU Vice President for Research, also a family foundation, and the Organization for Autism Research. My lab contributes a lot to the discussion we're having today. A lot of the work I'll be presenting is from students who have now graduated and moved on in the last couple of years, but we continue to work on these questions. And I'm really indebted to my international collaborators, especially Jackie Rogers, Sarah Cassidy, and Sebastian Gaig in the UK, and some recent work I've done with Carly and Andrea. So, and finally, shout out to John Adams, who has drawn the COVID corvids that I'm showing a few times here. John is a neurodivergent artist, struggling a lot with depression, with suicidality, and around PTSD and autism. And he's a big fan of the corvid family, jays and ravens and crows. And so during the last year, to relieve stress, he's been drawing what he calls his COVID corvids. And we're going to see a few of those, and he's given me permission to share generously. So we're just going to talk about recognizing depression in autism and some possible contributing factors that may be unique to autism and approaches to treatment that comes out of that discussion. I'm not going to get to everything. I'm going to mention a few things and then not talk about them more. But if you want me to stop on anything, go ahead and let us know in the chat. Okay.
And I'll just mention there's a number of microphones that are not muted. So maybe just check your mic quick before Mikle gets into the content here.
Yeah. Just mute yourself if you haven't. Thank you. I just want to talk first about recognizing depression generally before we get to specifics of autism. And really, I think most people know about the criteria for depression. Officially, there are 9 possible criteria, and you need to meet 5 of those. One of them is around depressed mood, right? Feeling sad or down or blue every day, most of the day, over the course of 2 weeks. Or we should say, a loss of interest or pleasure in things that you normally like doing. And we're going to come back to both of those later on when we talk about autism. And then you could have increased appetite or decreased appetite, increased weight or decreased weight, increased sleep or decreased sleep, or both, increased motor activity or decreased motor activity, or both, feelings of fatigue or lack of energy, very common feelings of worthlessness or guilt, even if you don't remember what it is that you did wrong. Just can't shake this feeling that I'm no good, I'm a burden to others. Difficulty concentrating, and then frequent thoughts of death. Doesn't have to be thoughts of killing yourself, but thinking about death a lot, and that can be bothersome. So those are sort of the general criteria for depression. And we do see variations in both timing and type. The average age of onset for adults is 26. I keep reading this in all the surveys. I see folks in my clinic across a lifespan. In the past year, I think we've diagnosed a 24-month-old and a 65-year-old and everything in between. I see a lot of depression in folks younger than 26. So those are the official numbers, but I certainly see it in children and in teens and in young adults. Generally, the earlier you experience symptoms of depression or have a depressive episode, the worse it's likely to be over the course of the lifetime. Although I've seen some data recently that essentially that's because you have more episodes. So it's not that any one episode is worse, but just that you have more of them. Sometimes people, will have one episode of depression and that's it. For many people, it's recurrent. I saw a woman yesterday, 23-year-old student here at BYU, and she's essentially been depressed since she was 12 and hasn't ever had a couple of months where she wasn't feeling depressed. So we have major depressive disorder. That's what most people know about. That's at least 2 weeks of symptoms, and then it may come and go during the lifetime. But frequently, especially in kids, we'll see persistent depressive disorder, kind of the Eeyore syndrome, like, oh, bother, something's not right, just feeling down all the time. Not quite as severe as we'd see in a major depressive disorder, but kind of long lasting. And people don't realize that there are other ways to feel. You just kind of get used to feeling down or blah all of the time. And of course, there's bipolar depression. I'm going to say that bipolar, by the time, especially an adult woman or a late teens or young adult woman or even men come around to see us for a diagnosis of depression, they've almost always been diagnosed with bipolar disorder. That kind of means a clinician saw them and it was complicated and they didn't know what to diagnose. And so when clinicians see complicated, they tend to either diagnose bipolar or borderline personality disorder. We see many, many autistic adults who've been diagnosed with both or either. But it's often not a true bipolar. And I'm not going to talk more about that today, but I think as we look for what it means to have autism traits versus what it means to have symptoms of bipolar, sorting those out is important, especially if it comes to like giving medications. I will say that I see children and adults, but a lot of my research right now is with adults, sort of because the children I was studying grew up and we're still following them and bringing in more adults through our clinic. So I hope that what I say will be relevant for children and adults. I think it is, but the state of the research right now, for my research and others, we're sort of starting with adults and then heading to younger ages, but still a lot of my talk, a lot of the data I present is going to be based on adults. Okay, what's the prevalence of depression? This is data from the CDC in 2019, where they did surveys and asked people over the last 2 weeks, what symptoms of depression have you experienced? Overall, it's about 20%, and you see the severity, mild, moderate, and severe out here. And then we can look at ages. This is the blue, dark blue, 18 to 29, then getting progressively older to 65 and older. We see, at least for mild depression, sort of a little bit more for the younger ages. Overall, 21% of folks 18 to 29 report any severity of depression over the last 2 weeks. But overall, these numbers hang around 20% of for any depression, and most of it mild, but a little bit of moderate and severe depression too. So we kind of remember that 20% number for what we expect in a neurotypical or a general population. How do we diagnose depression? Anyone working in medical or mental health fields will know this. sort of just ask people, really. There are some standard interviews. There are some questionnaires. On the right here, I have a standard questionnaire. This is the PROMISE group, sort of a federally funded research group to efficiently ask people. And on a 1 to 5 scale, I felt worthless. I felt I had nothing to look forward to. I felt helpless. I felt sad. I felt like a failure. It's not rocket science. There aren't any tricks. You just sort of ask people, are you feeling depressed? And people can tell you I am or I'm not. QPR training for suicide prevention is really just, if you see something, say something. If you see somebody looking down, just ask them about it. Don't be afraid. You're not going to make enemies probably, and you might actually save a life. There might be some needs to follow up. And I recently spoke with a woman telling me after she had her 3rd child, she went in for her postpartum visit, and the midwife said, "Are you feeling depressed?" She was, but sometimes in depression, thought processes don't always follow logical paths. That's a symptom of depression. And she thought to herself, well, if the midwife has to ask, then I must not be, because otherwise she could see. So she told the midwife no. But she told me she ended up being depressed for 2 or 3 years after that, and had a significant impact on her life. And I just wonder if, she just said one more thing, yes, or if the midwife had just asked one more question, like, you do seem to be feeling kind of down. Or if you know someone, you might say, you don't seem to be yourself at the moment, right? You're not enjoying things as much, or you seem to be kind of agitated. How are you feeling? So there aren't tricks, just be direct and ask people. We'll come back to that more when talking about autism too. Treatment, often the most common approach here in the United States, especially once you get into the Midwest and West, is cognitive behavioral therapy that works sort of changing maladaptive thoughts. If you have a thought, nobody likes me, maybe I'll kill myself, you just work turning these thoughts into more productive thoughts. Mindfulness approaches take a different approach, which is not to change your thoughts so much, but to become, to acknowledge your thoughts and to separate yourselves from your thoughts. So you can accept yourself. So I've had this negative thought, but it doesn't define me. I can be a good person and I can be a happy person, even though these negative thoughts keep coming through my head. And of course, medications are common, the SSRIs, Zoloft and Prozac and others, which try to keep serotonin hanging around in the brain a little longer. There are other medications. They affect serotonin or norepinephrine or other things sort of universally. So there's a lot of side effects around eating and sex and sleep and things like that. And there's not, a ton of knowledge about how to help any one person with any one drug at any one dose. It's a lot of trial and error. And so people have to sort out what's the cost benefit analysis on side effects and benefit from the drug. So those are kind of standard treatments, and people with autism often say that standard CBT treatment doesn't help, and at least the short time that it's often given. Data show, I have to say, so research data show a fair bit of benefit for CBT and autism, actually. Autistic self-advocates that I talk to and families and children are less bullish about how much CBT has helped them. I will say that. So I want to talk about autism and depression. So I'm going to take one question now from Marie that she didn't get a diagnosis of depression until she was 19, but first experienced depression with suicidal ideation at 14. It's common. Now, I have a select sample, of course. I'm not looking at a whole population. I'm only looking at people that come to my clinic or come into our research projects. So definitely, I'm going to see people who are struggling, but I see a lot of people who are struggling at early ages. So what can we understand specifically about autism and depression? So I'm going to go through a few things here. This is what we know about the numbers, and the the real answer is we don't know. For a number of reasons, we don't really know how much depression is out there in autism. It's probably the second most common associated mental health concern we see after anxiety, but also sorting out anxiety and depression is not an easy thing to do. They play together a lot. This is an interesting study from Betsika and Sharpley, published in 2015. They, and I can't remember the number, how many autistic boys. It was a fair number, where they did sort of full interviews with the boys and with their parents, specifically focused on depression. None of the boys had been previously diagnosed with autism, but after doing a careful evaluation, they diagnosed 43% of them. So that's a really big jump from 0 to 43%. That number, maybe 40, maybe 50%, feels kind of right to me about how many autistic folks we see, especially adults who are experiencing significant symptoms of depression. There may be more ups and downs in autistic folks than in others, but as far as significant levels of depression, maybe the 40 to 50% range. There are difficulties sort of sorting out autism from diagnosis. So one thing that's common in autism is a subdued emotional expression, and maybe a reduced motor activity, and even reluctance to make eye contact. Sleep patterns are by definition disrupted in depression, or at least commonly, but we know sleep patterns are disrupted in autism almost universally. So seeing someone and saying, well, you're not making eye contact, you're having a hard time expressing your emotions, you're not sleeping well, is that autism or is that depression? And unless you're thinking about both, you might miss it. Also, questions get interpreted differently. So a common trait of depression that people talk about is feeling blue. Now, most verbal self-advocates and people diagnosed with autism, or not diagnosed, but experiencing autism, will know from enough context that it doesn't actually mean you're feeling blue, but there are a lot of questions like that that can be mixed up. Some that I have experienced, I had an autistic teen taking questionnaires across the room on the computer. And then he got to the question that says, I have difficulty making decisions. And he sort of asked me, well, what should I put? And I don't tell people what to answer on surveys, except for there I said, you can put yes, because they had difficulty deciding whether they had difficulty deciding. And then I think I'm going to talk on the next slide. Oh, I missed a slide.
Yeah, just a question here, or actually a comment here, Michael, again from Marie. Marie just commented that CBT is helpful, but there's some problems with it, particularly over the long term with therapists who are not familiar with autism. And DBT is, she has found that more helpful, but there's very few programs. So it's hard to find a qualified therapist to attempt it one-on-one with.
Yeah, and it's a good question. Marie, let's come back to that at the end too. I have in the past week in my clinic, I typically see people once a week for an assessment, but for various reasons, this week I've seen 4. And yesterday I saw, just yesterday, it turned out, a transgender 22-year-old, born a woman, now sorting out where they want to go next with gender. I saw a lesbian 23-year-old woman, and I saw a mother who came for diagnosis of her 6-year-old boy that we did diagnose with autism. But she also said she's on my waiting list for an assessment. Unfortunately, and as Marie's talking about this, my waiting list now goes through next April. And I feel terrible about it. I am going to get the mom in actually next week. The mom has some gender fluidity issues. And issues may be the wrong term, but asking questions, concerns about that for her. And there's just not enough help out there because all of them have tried psychotherapy. And none of them have found psychotherapy all that useful. And so I'm thinking a lot about what is it about going back to see your therapist. One woman I saw who's pretty suicidal, that we could make therapy more helpful. And as Marie says, there aren't a ton of therapists, especially for DBT, which there is growing evidence for the usefulness of DBT in autism treatment. I'm sorry I left that out. But I'm sort of thinking, rather than get a ton of people more specialized training, let's get, it's going to be easier to get more people, maybe a little bit more training to think about how to treat autism differently. And so that's a lot what I'm thinking now. And actually, with the 4 people I've seen this week, I'm thinking maybe we just write a book, because write a book for therapists and for adults and for parents to just say, here's some of the unique aspects for anxiety and depression and PTSD that we see in autism. So what could the sort of average Joe therapist do to do better with autism? That's what I'm thinking today, at least. So standard mental health assessments and treatments, as Marie points out, may miss symptoms in autism. In fact, Sarah Cassidy did publish a study in 2018. She reviewed 12 standard depression measures for validity for autism and found 0 of them had established validity for autism. The Beck Depression Inventory, the BDI-2, is pretty commonly used for depression symptoms. It's not a bad measure. For me, it overfocuses on the somatic symptoms a little bit, basically the body symptoms. So I've given it a lot, and I've given it a lot to autistic teens and adults. And I just find some really funny stuff happens. For example, one of the questions is, over the past 2 weeks, have you lost interest in sex? And I hear things like, well, I don't know how to answer this. I never had an interest in sex. So what am I supposed to put? Or a young adult woman we saw recently who sort of has a moral objection to anything related to sex, the word sex or any talk about sex or any pictures or anything. And she gets really, really upset. And so she saw this question and she got upset. Now I called her mom after we were finished, just let her mom know. And her mom actually kind of laughed a little because she knows that her daughter gets just really upset talking about this. But that's a question, a standard question on the BDI that throws people off. Now, Sarah Cassidy has just this month published a new assessment for adults where she put together focus groups of many autistic self-advocates. They had long discussions about items, and then they sort of made the questionnaire, and then they sent it back to autistic adults for vetting. And then they ended up giving it to a couple of hundred adults diagnosed with autism, and found 3 factors. One is somatic symptoms, body feelings like, having more difficulties with sleep than usual. I forgot to bold the more here because that is in the questionnaire, just to let the people taking it know that, right, you may often have difficulties with sleep, but are viewing more difficulties with sleep than usual. Then cognitive thoughts, pretty standard. Are you feeling depressed? But they add just a few qualifiers in case people see things a different way, such as feeling sad or down, not feeling blue. We leave that for the avatar, but feeling sad or down or depressed. And then they found about a third of the questions fit in sort of maybe unique autism profiles. A desire for things to stay more the same than usual, or being bothered by things changing more than usual, or rather than just talking about motor restlessness or wanting to stim more than usual. So trying to put autistic language and autistic examples into there. And they're finding that this new assessment works pretty well. It has just come out. I, for one, will start using it in my research. And, as I talk about it, I'll probably adapt it into my clinic as well. So that's some of the work that's being done now to say, we don't have good measures of depression and autism. Maybe there's some more coming. So there's more hope. Okay.
Michael, there was a question about EMDR. Do you know what the research says as far as effectiveness with autistic individuals?
You know what? I'm going to have to plead my ignorance here. I don't actually know.
Right. Well, and it's more a trauma, focused treatment. So
Yeah, but
Yeah.
on that, right, many of our autistic folks have experienced trauma, and there's a whole line of research right now. Essentially, the standard criteria for PTSD don't fit autism all the time any more than the standard criteria for anxiety or depression fit autism. And so there's a lot of talk about what it means to have PTSD, and then would a trauma-focused treatment help if the sort of origins of the trauma or the experience of the trauma is different. How would EMDR work? So it's a good question. And Marie, coming back to hyperconnectivity and stuff, that's a good idea, and we can come back to that. I think I would like to come back to that at the end. I'm going to say, Marie, that the hyperconnectivity, especially with regard to sensory stuff, is a pretty standard part of a talk I give, and I've taken it out today because I just wanted to focus more on depression. But if we want to come back to sensory and connectivity, maybe we have time at the end. Okay, and then here's someone saying using EMDR to address sensory concerns. I could certainly see making a case for it. So here's work from Laura Crane and others that's really important, I think, and she calls it diagnostic overshadowing, which is if you have autism and come see a therapist who specializes in autism, they may focus on the autism, but I talked about how depression and autism have some shared traits for sure, and they might overlook the depression just as much, and maybe more frequently, in fact. You go see a therapist, many people are experiencing dealing with autism or depression, anxiety, and they're like, you're depressed, and completely miss the autism. I see that a lot. I mean, as people come to talk to us about autism, almost every adult woman I've ever seen that came for an autism diagnosis that was missed earlier had been diagnosed with depression. So this is the overshadowing. It really can go both ways. And so we encourage all clinicians, nurses, speech therapists, social workers, psychologists, psychiatrists, general practice doctors, everybody, to have both in mind all the time. One does not preclude the other. And in fact, they go together a lot. Being depressed doesn't mean you're going to have autism, but having autism, there's it's really worth asking whether there's depression going along with that too. Okay. Oh, I think I missed something earlier. Okay. So this is data from my lab about depression and autism. So remember this line here, 20% of the general population in the United States is experiencing symptoms of depression at any one time. Here, and this is a group of, I think, 75 autistic women. 20% are not experiencing symptoms of depression at the time that we interviewed them. So it's completely flipped. 40-something% are experiencing moderate symptoms of depression, and 30-something% are experiencing severe symptoms of depression. So that's really flipped, right? That's 80% of the women that we saw in our research project saying, I'm experiencing depression right now. And then new data just coming out from my student, So-Yeon Park. She has surveyed, I think we're at now 120 autistic adults. About 70% of those have a confirmed autism diagnosis. The other are self-reported. But 70% of those we surveyed have reported a co-occurring mental health diagnosis. So they have been diagnosed with depression or anxiety or something else. And then here's the PROMIS scale I showed you earlier, a few questions from it. I think the cutoff for being concerned about depression is somewhere around 11, somewhere in the 11 to 12 range. And the average for both males and females in our group was over 20. So I said maybe 40 to 50%, but of the select samples we're using, we're studying mental health and autism, we're seeing really high rates of depression. Okay. So now we need to think, are there some unique things about autism that increase risk for depression or change the expression of depression? Maybe it's missed, maybe it's not treated adequately. There are lots of questions here, and I've thrown down 6 ways to think about things. Each of these literally could have its own talk, and I'm not going to talk about most of them. I do want to mention that some of the biology that we see is common in autism, including some of that hyperconnectivity that Marie talked about, other links from regulating emotion, going from amygdala to hippocampus to prefrontal cortex and so forth. The brain isn't divided into lots of little boxes. There's depression there, anxiety there, ADHD there, and autism there. We're really talking about the same symptoms, the same systems, the same systems. And so there may be something in the system that sort of increases likelihood of autism that also increases likelihood of depression. There's lots and lots of work going on in that. Sex differences is a big area of inquiry in depression outside of autism and inside of autism. And I guess that there's going to be an interaction so that the sex differences we see in depression outside of autism are not quite the same as the sex differences we see inside of autism, especially when it comes to really frequent experiences of gender fluidity, gender confusion, gender differences, gender dysphoria that are seen in autism. And I see the gamut, people who are very firm in their non-cisgender identity, a lot of people that have a lot of dysphoria, a lot of fluidity. So just gender questions come up much more. I tried to track down prevalence in that a couple of weeks ago and saw studies that anywhere from 15 to 25 to 35 to 45 to 55%, depending on the study, who they're asking, how they're asking it. But this week I've seen 3. So just in my office, it's common. I am going to talk a little bit more about the relationship between autism traits and camouflaging or masking, which is common, but it's also complicated. And there's like 3 papers come out just in the last month, sort of questioning the way we've been talking about camouflaging for the last couple of years. And it's always good to get more perspective. I want to talk a little bit about the way autistic people think in general. Obviously, every autistic person's different, like every person's different. But we do see some themes for the way we can talk about emotions, and then especially intolerance of uncertainty. And then I really want to talk about a new way of framing autism in relation to non-autism or neurotypical people, and to suggest that we've been doing it wrong. We've been doing it backwards. So going to get to the double empathy problem. Okay, this is just data from my lab again. On the y-axis is autism traits as measured by the SRS. The SRS isn't a perfect measure, but it's pretty common. And then this Tennessee self-concept scale. And really what we find is autistic women are self-reporting that the more autism traits they report, the worse they feel about themselves. I think I'm going to continue to talk about ideas around that data, but that's just the data that we found. So more autism, and really there are only a few people that are in this sort of not worried about self-concept range. Everyone else is some or significant disruption of self-concept. Okay. So I want to talk about camouflaging. Here's another one of John's COVID corvids. And here's a quote from one of the women in our study. Yeah, I'm really good at faking it. I normally smile when I'm sad, or like there's a lot of times I don't know how to react. Like when I said goodbye to my family before leaving for my church mission. I wasn't sad, but I felt bad about it. Like I should be sad and I should be feeling this, so I contort my face to please other people, but it's not actually what I feel. And I apologize a lot, and that makes it more awkward. And also because sometimes I'm supposed to feel a certain way, but I don't, so it's just awkward. People get annoyed because I don't feel the right things. And so we see so many people that have learned, oh yes, I need to make eye contact with that person right now. Oh, I'm supposed to smile, right? Oh, you know what? That person just said something, I need to respond to them. Now, this mother I saw yesterday of the 6-year-old kid who I'm pretty sure we will diagnose her with autism, but I was talking to her about intolerance of uncertainty and said, here's an idea. And so I wrote intolerance of, and I'm sorry if anyone's offended, but she just said bullshit. She said intolerance of bullshit. And I'm like, you know what? I'm going to use that because autistic people may see the world more accurately in many ways. The sensory world, certainly. And then, you know, the social graces that neurotypical people pull off are most often a lie. If someone asks you how you're doing and you're actually not doing well, the answer is still going to be, I'm good, fine, no problem, right? So there's just this disconnect between seeing the world accurately or saying the world accurately and being able to sort of fit in. So autistic people learn to fit in, but it's a lie that they aren't comfortable with because, right, they prize truth, they prize honesty, they prize reality. And so now they're supposed to put that aside just to fit in. As Marie says, a zero tolerance policy for cognitive dissonance. So why are we quote unquote blaming by like rejecting, treating badly, bullying people for speaking truth? So our autistic people learn to fake it, but it's not good, or is it? That's a question. Here is data again from one of our studies showing that the more time spent people spend camouflaging, the worse is their mental health distress. Here's suicide risk, and here's any mental health concern. So what we've been arguing is more camouflaging is worse for your mental health. Now, as I said, there've been a few papers come out in the last couple of weeks, and Michelle Dawson, who's a well-known autistic self-advocate, picked up on one of these to say these are correlational data and we can't make those causal jumps. We need to be careful how we define camouflaging, and we need to be careful about the sort of causal leaps that we make. So I'm trying to take that all into account and be more careful, but these are correlational data, but our data show higher distress with higher camouflaging. Now, this is very interesting. This is from Soyeon Park again, and this is a complicated figure. You don't need to understand it. I've highlighted two of the arrows. What we're looking for is vocational and educational success. This is self-reported jobs and education since turning 18. This is the WHODAS, an international measure of function and a vocational index created specifically for autistic people, but often for the less verbal autistic people, not being out in a more mainstream workforce. Anyway, that's what we're trying to predict. And we do see that we see some complicated relationships. Higher levels of camouflaging do predict higher vocational educational success. That makes sense, right? You spend more time trying to be like what you're supposed to be, like expectations for jobs and school, and it works. So people who camouflage more have more success. But we also see that people with higher levels of mental health concerns have more vocational and educational job success. Now, there are different ways to think about this. Maybe being more anxious leads you to do better at your job because you're a perfectionist. But what we're probably arguing is that more camouflaging leads to better job success, but it takes a heavy toll on mental health. Okay, I'm running out of time and I see some great stuff in the chat. So good ideas to think about, all of them relevant. I'm going to say there's just so much work that needs to be done here. Lots. And these are good ideas, but I want to get to a few treatment recommendations at least. Ooh, I can't skip the double empathy problem though. Okay. So in all the time I've grown up in autism research and clinic, we're like, autism has a deficit in empathizing with others, with neurotypical people. They don't understand thoughts and feelings. It turns out that non-autistic neurotypical people have exactly the same amount of difficulty empathizing with autistic people as vice versa. It's a two-way street. No one is better or worse than the other. Here's some data from colleagues of mine in Dallas. They put autistic people talking with each other for 5 minutes, neurotypical people talking with each other for 5 minutes, unscripted conversations, and then a mixed group. everyone thinks that the autistic partner is more socially awkward, more socially difficult. The autistic people think the same about their autistic partners, but the autistic people want to hang out with each other in the future. The neurotypical people want to hang out with each other in the future. It's the mix where people are like, oh, that's not working so well. Okay. So the results here at the bottom, results support reframing social interaction difficulties in autism as relational rather than an individual impairment. It's not the person with autism, it's the relationship with the person with and without autism, and it's a two-way street. A little more on that. If you play the telephone game where you say something and then they say it to the next person, they say the next person, and so on forth down the line, again, they had all autism, all non-autism, or mixed. And the autism and non-autism were exactly the same with accuracy. When using the same style, autistic people don't have a communication deficit. They can communicate with each other just the same as non-autistic people communicate with each other. The trouble comes in the mixed scenario where you have different styles. And in this case, the success of the interaction was predicted by the social skills of the non-autistic person, not the autistic person. It's the ability of the non-autistic person to say, I'm dealing with someone with autism here, we can work together, okay? Okay, I'm not gonna have time to talk about intolerance of uncertainty, although this is, in my view, well, this is all my research, maybe the biggest factor that we see affecting autistic people with their mental health, just always being uncertain what's gonna happen. And for sensory reasons and social reasons and emotional reasons, just a lot of confusion in the world because there's so much data coming in. It's hard to sort out what's the most relevant data. I was going to show a study here, but I want to give the takeaway here is not that autistic people are more afraid when they're supposed to be afraid during threatening context. It's that autistic people are more afraid when they don't need to be, and it's a difficulty finding when to be safe. It's difficulties feeling safe. And so if you don't know when to feel safe, the takeaway is, well, maybe you should feel threatened. And so a working hypothesis for us is that some of the anxiety and depression we see in autism is because of difficulties finding safety. This is important for treatment because cognitive behavioral therapy, for example, relies on you coming back to your safe place, right? You have to have a safe place that you can bring yourself back to emotionally. Well, what if you don't have a safe place? And so therapists are gonna be saying, get to your safe place. And you're like, I don't have one, right? So that's where that comes from. I also want to talk about mindfulness and just show a little data here. On my graph didn't come out well, but we've just published data showing that an online self-administered mindfulness program did well as much as standard CBT, well, also online CBT at reducing, this is depression scales, and this is overall mental health. So there's a lot of data coming out from my lab and other people's lab that mindfulness treatments could really be useful for autism in an autism specific way. You may need to modify some things. I want to give this as really a lot of hope. The blue line here, so I'm going to go with the gray line. These are people coming into University Counseling Center, BYU. This is their distress score when they start. This is their distress score when they end. This is autism, distress score when they start and distress score when they end. They're the same. There's no difference at beginning or end. The difference is how much time it takes. And a lot of autistic people are just saying, it's going too fast, it's going too fast, it's going too fast. Just slow down in the session, and then we need to argue for more sessions, which many health insurance companies and treatment centers are limiting the number of sessions, sometimes to 4 or to 6. And say, that's not enough. 6 sessions is not enough for someone with autism. Okay. So if we want to look out for depression and autism, I'm going to go with the same rules. Just ask, right? I might ask frequently and ask directly. An autistic research assistant that works for me called me 2 Fridays ago. So about, I guess, 13 days ago. No, she texted me and said, it's not your fault. Thanks for listening. It's not anyone's fault. It's my fault. Tell the lab I love them. I can't take it anymore. Goodbye. That was a a startling text, but not surprising. I'd been talking to her all week. And so I called her, and thank goodness we had cell service, because that's not always the case. And I asked one simple question: where are you? I didn't ask, how are you feeling? Or tell me what's going on in your head right now. I just said, where are you? It took her some time to respond. I gave her that time, right? I didn't rush her. And then she said, I'm in the mountains, and I've come here to end it. So it took 2.5 hours on the phone with her to talk her down, all the way down the mountains and through town, and eventually to the counseling center and the police car, where she got to the hospital and is doing in some ways better now, and still some struggles. But all the way along, I just was very direct and simple. And before she went to the counseling center, I had her sit down on a bench outside and said, if you go into that counseling center, they're going to make you go to the hospital. So I just want you to know what's going to happen. But just talked. There's no tricks except for be concrete, be direct, be frequent. And most people I know will speak truth, although she had earlier in the day lied to her mom when her mom said, are you doing okay? And she said no. So, we don't always get it right. But I am saying that standard treatments for depression may take more time. I'm going to say will take more time, and have to account for additional contributing factors: sensory sensitivity, a need for certainty, a need to feel safety, but also realizing that being bullied every day is a thing. And if you're bullied at school or at work, a therapist could say, well, why don't you just reframe this as a negative thought? But the fact is, you go to work the next day and people are going to give you grief because they don't understand you. And so we have to be really sensitive that having autism means dealing with a lot of extra crap that many people don't have to deal with. And so therapists need to take that into account. Okay. May need to be very explicit, especially for teaching emotion awareness. That is a frequent area of challenge in autism, is differentiating. You feel emotion, but without the words or the labels to put on them, those emotions can become pretty overwhelming and sometimes shut down. And then working on safety cues and threat cues. I think if I'm treating depression and autism, these are some of the things I'm going to want therapists to be aware of. And I'm always happy to talk to therapists of people I see and just give some advice. All right. There is some thought that mindfulness and acceptance may be helpful, just cutting down on the alexithymia, the emotion difficulties, and leading to less anxiety, less depression. And I'm just going to say there's this urgent need to prioritize mental health treatment and suicide prevention. Sarah Luderman, who's an autistic self-advocate, a journalist in Washington, D.C., she points out people like me and Jake Michelson, we get lots of funding to study genes and biology and stuff like that. She says there's lots of research dollars out there for zebrafish, studying zebrafish. And zebrafish are interesting with regard to autism, but there's much less money about figuring out why so many people with autism are dying by suicide. The rate of suicide in autism is somewhere between 3 to 9 times higher than the rate of suicide not in autism. So it's a big concern. So we just need to prioritize things in the right place. Now, Myra has asked, how can I get some of this information? I've just been writing a lot of stuff. So if you email me, maybe Kelly can put this in the chat. My email address is south, S-O-U-T-H, like the direction, south @byu.edu. I'll send some materials I've been writing. Some of it more for adults, but I'm trying to think now, what could I provide to therapists to be more helpful, okay? I just want to end with C.S. Lewis, who says, it takes all sorts to make a world. If grace perfects nature, it must expand all of our natures in the full richness of the diversity which God intended when he made them. And heaven will display far more variety than hell. So I think just accepting people with autism, people without autism, we all need to accept each other, learn that there are different styles for communication. That's okay. We need to just learn to read each other, to get along with each other, and take away the need for so much camouflaging, as what I would argue. I think a lot of depression, anxiety we see is around trying to fit in to a place that you don't understand. and being rejected because other people don't understand you. It's how we go. So I'm going to end my slides. I do have a crisis resource slide, but if you need those, please just email me. There's a lot of questions that come in for the chat. So
I was just going to say, Jake had one earlier,
Okay.
but I knew you wanted to get through that treatment stuff, so I didn't interrupt you.
Yeah.
But it's a very interesting
So
question.
about gender diversity and gender diversity, sexual diversity, and mental health. Is that what it's about? Okay.
And a little bit of culture.
Yeah, Michael. So yeah, I guess I was a little rambly in my comment, but I'm especially curious about the specific cultural context that you're in, and the role. We talked a lot about minority stress as a contributing factor to all sorts of mental illness, but in particular depression, which we're obviously talking about today. And so I'm curious. The core of the question was, do you spend any time or a lot of time navigating religious taboos in your practice, and how does that factor in, especially with people who are gender diverse? And then secondly, kind of building on that, is there a way that one could actually, take religious circuitry and hack it in a way that actually promotes things that reduce minority stress in that kind of a context?
This is a good question. It's a loaded question since, as Jake knows, yesterday, a prominent therapist in the Church of Jesus Christ of Latter-day Saints, the Mormon Church, was thrown out of the church, somewhat related to her views on sexuality and stuff and Mormonism. I'm going to say this, and I'm not afraid of getting into trouble, but the lesbian 23-year-old BYU student I saw yesterday has had several suicidal episodes in her life around her feelings of moral failure within that religious context. And about a year ago, she decided to leave the church, and she's feeling much better. I won't say much better. She's feeling less suicidal. She's still depressed. And as Jake put, I think she has some intrinsic stuff. She's been depressed since she was 12. There are some family issues. There's some personal issues. I think there's some biology for her. In general, just so you all know, and I know Iowa has a highly religious culture as Utah does. In general, religion and religiosity is beneficial for mental health for lots of reasons. There are lots of reasons in general, but it's not true for everyone specifically. There's an interesting sociology study published yesterday that women in highly conservative religions where they don't have decision-making power, where they're sort of left out of the power structure, they're less benefited by religion than more equitable religions. And that came out yesterday, I saw. And certainly for the people I see, especially for gender diverse people in a culture where gender diversity is very frowned upon, there are big conflicts. And I can say recently, I felt like I was at a tennis match. I was in my office and had a 26-year-old born male, transgender person struggling with depression. We decided not to diagnose autism. We diagnosed depression, but not autism. But my PhD student was on one side of the room. The father was on the other side of the room, and they were talking back and forth, one of them using he pronouns and one of them using she pronouns. And the father said, "I just know there's a precious daughter of God in there somewhere." Well, the person themselves is like, oh no, they were born female and now identified as male. That was it. And so they want to identify as male, but their dad sort of won't let them go. And so, yeah, Jake, I see this a lot. And right, I can't navigate this for people, but we do talk about it. We do talk about it. And so,
Thank you.
I'm-
I did not expect, a conclusive answer. I was just curious on your thoughts, and that's very interesting.
I'm thinking about it a lot because like
Yeah.
yesterday I saw 3 gender diverse people in one day
Yeah.
in this highly conservative, religious, anti-queer
Yeah.
culture,
Yeah.
right? It's changing. I can say at BYU among the young students, I have last semester 5 or 6 openly queer students in my intro psych class. I'm sure there are more, who weren't open. We had discussions about it, some pushback, some homophobia for sure, but much more openness. But I do see the young people still struggling with those really constraining gender norms.
Yeah. Well, I'm glad they've got you, Mikle. Awesome talk.
It's rough, Jake. There's a lot of pushback, not from administration, but from students, who are learning. Marie has had a lot to say. Marie, can you just talk for a minute? Because you've had a lot to say. What would you say? What would your takeaway be about autism depression? Are you willing to come on and talk?
Yeah, I don't have a problem with that. Well, just basically like anytime your worldview and the way you work is fundamentally opposed by the expectations everyone else has for the way you work. I mean, depression is not the problem. Depression is the solution when you're growing up autistic.
Yeah, right.
Same with anxiety. I mean, really with me, it's the anxiety was the solution to the mismatch. And then after I had high enough anxiety long enough, I would hit depression, and that was the solution to the exhaustion from all of the anxiety. So, yeah, it just, I don't know what to say other than I have so many things I could say.
Right, and obviously
prioritizing things.
Jake has more, and I had to prioritize a few. I didn't even get to some of the few that I prioritized. I think we need to talk about it more, but we need to especially get to therapists, right, who are treating this and say, you're missing some key stuff. And so with maybe a few tweaks, we could get more better. But my ideal solution is to stop training autistic people to have normal social skills. It's just train our whole world that we need to accept each other for our differences, and learn to communicate with each other better, right? It's a two-way street. It's 12 o'clock, so, or I guess 1 o'clock, 12 o'clock for me. If you email me, I know Sarah has some questions here. I can send something. I'm willing to stay on if people want to stay, but obviously it's time for people to go. So it was really fun being with you. And I hopefully someone can send me this chat because there's lots of useful stuff here. And I'd like to hold on to some of these ideas you guys have.
Thank you so much again, Mikle, and hope to be able to do this kind of thing in person again soon.
Yeah. All right. Great. It's good to see you all.
Take care, everyone.
How many people ended